Welcome to this explainer. We are handing you the ultimate cheat sheet today to demystify the highly specific and, let's be honest, often frustrating rules around suprainguinal atherectomy coding. Look, if you're a medical coder, a biller, or a healthcare professional, you already know atherectomy is a super common peripheral vascular procedure. But you probably also know that coding it correctly can be a massive headache because the rules literally change depending on which artery is being treated. So today, we're breaking down everything you need to know in plain, step-by-step language. Here's our roadmap for today. First, what is an atherectomy? Second, the golden rules of coding. Third, the suprainguinal code breakdown. And finally, embolic protection devices. Let's get into it.
Section 1. What is atherectomy? Let's cover the core clinical concepts.
Okay, so at its core, an atherectomy is a procedure used to physically remove atherosclerotic plaque, that fatty buildup, from inside an artery. Basically, a physician inserts a special catheter fitted with a rotary cutter, and they carefully guide it through the artery using real-time imaging. Now, the key phrase here is that it physically removes the plaque. That core clinical concept is the absolute foundation of why this procedure requires entirely different coding pathways from, say, other vascular procedures.
And this really brilliantly illustrates the macro difference you have to keep in mind. Angioplasty and stent placement, they work by just pushing or compressing the plaque against the artery wall to widen the vessel, kind of like squishing it out of the way. Atherectomy, on the other hand, actually gets rid of the plaque by cutting, shaving, or vaporizing it completely away from the arterial wall. Because the underlying goal is removing the plaque rather than just compressing it, atherectomy gets its very own dedicated set of CPT codes.
Moving right along to Section 2, the golden rules. These are your universal coding rules.
Physicians generally use 4 primary device technologies out there in practice: orbital, rotational, laser, and directional atherectomy. But here is the fascinating takeaway for coding purposes. The technology doesn't actually matter. Seriously, if you take only one thing away from this section, let it be this. The CPT code does not change based on which of these devices is used. All 4 device types are coded the exact same way. You've got to base your code selection on the type of procedure performed, not the fancy equipment they use to do it.
So, the crucial point is this: code the procedure, not the brand name. And physicians, if you're listening, here is a quick documentation tip for you. Make sure your chart notes explicitly state that the procedure was an atherectomy. If you just jot down TurboHawk or SilverHawk, you are basically handing insurance companies an easy excuse for a frustrating claim denial. Chart the action, not the tool. Now here is our #1 universal constant in the atherectomy coding universe, a rule that applies to every single artery. No matter how many times a catheter passes back and forth to clear that plaque out, you only assign one atherectomy code per artery treated. That's it. Multiple passes in the exact same vessel absolutely do not equal multiple billable procedures. It is one code per artery, period.
All right, Section 3, the suprainguinal codes. Let's break down codes 0234T through 0238T.
Coders, you'll want to pay super close attention here because you cannot mix these 2 code sets up. There's a hard geographic split in the body when it comes to this. If the atherectomy is performed below the inguinal ligament, meaning down in the legs, you use one specific set of codes. But if the procedure is suprainguinal, meaning above the inguinal ligament and not in the legs, you must use CPT Category 3 codes 0234T through 0238T. Today, we are focusing strictly on those Category 3 suprainguinal codes.
These suprainguinal codes apply regardless of whether the procedure is done as an open surgery or via a percutaneous through the skin approach. Now, what's really important is understanding what is bundled into these 5 codes and what isn't. Code 0234T through 0238T automatically bundle the atherectomy procedure itself and the radiological supervision and interpretation needed to perform it. However, things like catheterization, embolic protection devices, other interventions, and closure devices, those are separately reportable when applicable. But wait. Let's think about that list for a second. Is catheterization always billed separately just because the general rule allows it to be separately reportable? You'd think so, right? Well, this is a trap that catches a lot of billers. The answer is actually no. The absolutely crucial exception to remember is that if another procedure performed in the same session already includes catheterization or closure, you cannot bill it again separately alongside the suprainguinal atherectomy code. For example, if a diagnostic angiogram is performed in the renal artery, followed by an atherectomy in that exact same session, the catheterization is already covered by the renal angiography code. You cannot double dip here.
You'll definitely want to keep this information handy because this is essentially your ultimate quick reference summary. It perfectly matches the specific suprainguinal artery to its corresponding CPT code and lays out its unique catheterization rules. Remember, the artery dictates the code. Renal is 0234T, non-renal visceral is 0235T, the abdominal aorta is 0236T, the brachiocephalic trunk and branches are 0237T, and the iliac artery is 0238T. Let's actually break these nuances down just a little bit further. Drilling down into those specifics, look at the renal and visceral arteries. For code 0234T, the renal artery, you do not add a separate supervision and interpretation code, and you only report a vascular catheterization code if a selective diagnostic renal angiogram was not performed in the same session. But for 0235T, which covers visceral arteries except the renal artery, you do report a vascular catheterization code, and you also report a diagnostic angiogram's S&I code if one was performed. It is an incredibly strict difference, so you've got to watch out for it.
Likewise, when moving to the aorta or the neck, catheterization is generally added. For 0236T, the abdominal aorta, you add the non-selective catheterization code 36200 unless selective catheterization was done elsewhere. For 0237T, upper extremity and neck arteries, you add the vascular catheterization codes, but pay special attention to the iliac artery code, 0238T. This uniquely mandates that you bill for each vessel treated separately. If atherectomy is performed and documented in more than one iliac artery, you report that code separately for every single vessel treated. And before we leave this section, remember this. If your documentation supports it, you absolutely can separately code for angioplasty, stent placement, or other interventional procedures performed in that exact same artery during the exact same session. They are coded separately in addition to the atherectomy code. All right, Section 4, Embolic Protection. Let's talk about some coding outliers. So because atherectomy actively cuts and shaves away plaque, there's always a risk of debris breaking loose. To mitigate this, physicians often deploy an embolic protection device. Think of it as a tiny filter or basket attached to a guide wire, placed just beyond the treatment site to catch that floating debris or thrombus. It's a fantastic clinical tool for sure, but coding for it, it's a massive trap. The sharp contrast here is vital for your claims. There is actually no specific CPT code for embolic protection, so how do you bill it? Well, if you're billing for a hospital under the Outpatient Prospective Payment System, or OPPS, the hospital may report HCPCS code C1884 when this device is used. But for physician billing, you should never report C1884. That code is strictly for facilities and hospital billing only. If a physician submits that code, it's just going to get denied. So as we wrap up this explainer on suprainguinal atherectomy coding, I want to leave you with a final thought to take back to your practice. Knowing that the specific anatomy dictates the CPT code, and not the brand name technology or how many passes the catheter made, how does your practice's current documentation hold up against these strict rules? Are your physicians charting the actual procedure, or are they just jotting down the equipment? It might be time for a quick chart audit to ensure you aren't leaving revenue on the table or setting yourself up for unnecessary denials, wouldn't you agree?